Good morning, everyone. My name is Bagum Dottum from EP Fellow with Johnson Severance Hospital. Let me present ECG conference case. Solzaya. Yes, help spread. So,
I think it's alternative from the LV and it's one but how much A6 and shape. It's in place the left side and quickly it was every A6 and shape this the LV7 and here the shape. Also, Mars A6 and Korea is positive to office mobilize and so indicates maybe that the rotation and also see them throw them on it in design.
Anything else? So, what information you trying to get from total ECG? First place, you need to know what's the rhythm, right? But it's not just that. EKG contain what else? Patient's basic cardiac function. So your interpretation is not even half a complete. Yes. So first thing you want to know, what is it driving rhythm this thing? Sinus rhythm or is it arrhythmia? Arrhythmia, which one is right? You got more P wave than QRS complex. Correct? Am I right? Am I wrong? Then sinus is driving heart. So this is a normal sinus rhythm. Let's start looking at the P wave first. You're not just the rhythm reading that. If you want to know about the patient, so what is the P wave look like? Now, P wave axis is what? Normal or abnormal? 5-5 leader one is the most constant, right? Is that normal? Normal?
Normal.
Abnormal. What is the P wave most dominant axis? Leader 2. Leader 1 is bigger than 2. So that means slight toward leftward axis deviation P wave. What does that mean to you? Perhaps left atrium is dominant this patient, which indicated by leader 3. Look at the leader 3. P wave is biphasic, correct? Third rhythm 3, and then negative portion is bigger than positive portion. Biphasic, right? That means left atrium is dominant driving this guy atrial activity. So start reading those things carefully. How about PR interval? Normal? Yeah, it's normal. So you assume AV nodal conduction antegrade released is normal. How about native QRS complex? Even before you look at your PVC vision, what do you think? Is this the QRS normal? What are the alteration looking for? Axis, voltage, what else? Duration. So if you look at the left three-quarter lead, look at the lead V1 to V6. What do you think? You're wondering if this patient meet the criteria for the LVH, yes or no? We didn't call that, right? Second is that the then axis is appropriate for that. Then which may contribute to the QRS duration, right? When you have a left ventricular hypertrophy, your QRS duration is going to be slightly wider than what you used to see. Not abnormally wide, but it will be wider because you got more critical mass to repolarize, correct? And then what do we have to see? Look at the repolarization. You know that the T wave always goes with the QRS complex, no matter what lead it is. So it's comfortable. Okay. So then your discussion going to be rhythm going to be sinus rhythm with the normal AV conduction, baseline rhythm, possibly left atrial enlargement, maybe voltage criteria was perhaps a suggestion of LVH, probably early stage without repolarization abnormality. This is your baseline interpretation. Now then you add your what's your abnormal finding. So we need to make this systematically because you're going to really get it like that in your practice. You're not going to look at the, oh, this is a PVC. No, that's not even half complete. So we really want to know whether this QRS complex baseline sinus rhythm has to do with this PVC. That's another thing we can know, right? Tell me whether QRS complex to the PVC complex is the same or vary. First question. What do you think? Fairly constant, right? Yeah, there's not much variation. Next thing you look at the axis of that QRS complex PVC with the sinus. What do you think? What the difference is? Lead one. What else? AVL. Yes. What else? Lead D1. Right. Otherwise, the axis is similar. Right. So then, where do you think is this PVC coming from? Everybody said the left. Yeah, it is the left side, perhaps because the lead one is negative, right? But we need to be more precise than that. E1 is a positive all throughout. Looks like almost like left side axillary pathway, right? But then AVL has a what? Deepest S-way. That means AVL is where? Lateral, not lateral. So you need to be more precise than that, EP guys, okay? And what else? Why the lead one is not QRS complex? PVC. That will give you answer. Why? Why is that? If you left lateral focus, would you give you lead one such a notching? You got, QRS, lead one PVC. Look at that, right? Like a double cent. Where they come from? That means it's not coming to the lead one. Coming and turning around and going back in. What can do that? Almost perpendicular activation, but it's long perpendicular activation of that. That is, this is more anterior mitral valve. Okay, almost isoelectric. So then you look at the PVC. There, where do you think that this PVC focus is going to be? Next question. Look at the PVC morphology. Upstroke is slower than downstroke. Correct. Remember we talked about integrous activation time. Your integrous activation time from baseline to the tip of QRS complex is longer than as coming down, straight down. What does that mean? Imagine the tissue that coming from the deep side, slowly activating. And once you hit the endocardium, activate the fascicles goes down. But can you imagine that? Kind of imagination? It's a deep focus, not endocardial focus. That much you can tell. Question is whether this meets the criteria for the epicardial source or not. Probably not. Not quite enough. And the second, if you had the epicardial from that area, you should see more notch QRS complex. And I don't see that. So then you argue, this could be mid-myocardial or perhaps a deeper tissue. At least you can say that. Or whether epicardial, but it certainly is not endocardium, that's for sure. Okay, while we are discussing this, if you decide to ablate this, then you need to start thinking how I'm gonna map this, right? That relates to your practice every day. I have to map what? Cardiac gain, right? For sinus, you gotta map endocardium. Decide whether you're gonna need the epicardial mapping or not, depending on timing, right? So those things comes in your mind here. Now, what is this P wave do? Did you measure the P interval QRS complex after that? There's any P wave? Do you see anything? Do you see any retrograde P wave? I'm asking. So you measure the PP interval, okay, from sinus to the following QRS P and then next P. Then you have to answer that question. That's why, yeah, that to the next P. Yeah, that one to the next P. Next one. Yeah, that interval. Between two, which one? Is they the same or they push it forward or they are? What do you think? Looks like following PVC P is a slightly shorter PP interval than following normal P. Somebody want to measure that? Go ahead and measure. Maybe I'm wrong, but I think it's slightly earlier. Right? Measure, yeah. Slightly longer. Right? Longer. So why is that? What difference can you make that? I'm asking. So this is important implication. You know, we often disregard this, but if you look at the lead, you know, B2 or B1, B2, I think it's a continuous shift. Okay. P wave with first go, preceding P wave with sinus speed. Okay, point that arrow that, you know, first P you measured the sound. Do you have arrow there? No, that before that one. Coming the first one. Before the PVC. No, the sensor, you just measured it. You got a pointer there somewhere? Back to, back to. Okay, that first P just before, that's not a P. Come back, no, come down to the rhythm strip, P1, P2. Yeah, that one, that's P. And then you got a PVC following P wave, right? Right, the next one coming down, yeah, that one, and then following one. So first of all, P of amplitude can fluctuate if you have a longer peak interval. Why is that? Because there's a longer recovery time, and then you have more before. Okay, more coupling time. Second thing is, this patient does not have what? VA conduction. Okay, if you had a VA conduction, would you reset that P wave? This is not much, just a little bit. So this is similar to what you see in heart block, ventricular phasic P wave. That's what you got. Yeah. So ventricular phasic P wave only seen when you have VA block. You don't see it when you have the conduction. That's another problem. So when we are reading this ECGs, you really try to get out as much information as possible from ECG for your procedure. I'm sure you guys have the ECG looking this because you're thinking about ablating this these days. Because unfortunately, we ablate first, look at later. That's a mistake. Okay, you can make that only a procedure longer. So get the data out as much as you can. And if you have a question, ask. Okay, and we can discuss it, and you can plan how to do this procedure better. That's why it's so important to teach you ECG so well. When you see a patient in your clinic, you're deep inside your mind, I'm going to ablate this thing. So you're anxious. Your hand is like a little tingling, I'm going to ablate this well. But you got to know what you're looking at. If you don't, you're going to make cause a problem. Okay. Where this most common this type of PVC come from? Mitral anterior annulus. How do you approach this? Transaorically or transarterically? Both. You have to go both. Okay. We just ablate a similar PVC, 3 of them last 2 weeks. Yeah, this come all from annulus, or just slightly under the annulus. So you don't know until you map which one is the best. But your cardiac gain catheter will be the reference. So you got to have a cardiac gain catheter. Great cardiac gain. Okay. because of, if this PVC has a preferential conduction pattern, can be even air to mitral contiguity. As the ECG only show where the PVC exit, doesn't show where the source is. So you need to define that as well. But this is very important structure here, very complex. So one of them was ablated, almost ended the aortic valve, one of these patients. The other one, anterior wall, and above the valve, transeptally we have it. The other one ended up going to the endocardium underneath, ended up with bipolar ablation. Yeah, because we did coronary angio, circle artery was right at the top of it, so we could end up putting cardiac vein to that endocardium. So this PVC can be very complex ablation. Yeah. So did you ablate this? What did you do? No,
Yeah, I'm like,
you did ablate. Okay.
always submit.
Mm-hmm.
Right.
LV summit.
Uh-huh.
Is this EKG pattern consistent with the summit? No, it's not. Because the lead V1 too tall. Okay? That means this patient has what we talked about, based about aortic contiguity exiting. So this is the preferential conduction attributes.
Mhm.
But one of the three examples I gave you. Okay? So sometimes EKG tell you, since the only exit site, if you want to do ablation, you got to have a little bit more broader differential diagnosis to make sure you prepare for that. And this two French catheter probably would be helpful. Did you guys put the two French catheter and the cardiac vein, ablate this? Did you use the cardiac vein two French catheter to map this thing? Okay. One of the cases we did had two French cardiac vein and the septal vein insertion of a catheter. Very first branch of the cardiac vein. Pick it up for the septum would be very helpful. You're going to see very early double potential, very sharp potential. Hopefully one day I can show you. And I have an organized case here. That is an important target to know where to apply. Yes.
Question. If you plan to ablate this, would you endocardial met first and then CS met if there is no good target, or would you do the CS mapping regardless? Because this seems like
Mapping mean you bring diagnostic catheters or you do 3D map. Which one you talk?
the micro
Microcatheter.
Yeah.
We put all of this in microcatheter, no exception. The reason is that very exactly the preferential conduction pattern. So if you thought that this anterior wall and you put a break cardiac vein, it's not early, then you know it's coming from the deeper tissue. Then you have to search it. Having catheter marker, basic diagnostic marker to the focus, close the focus is extremely helpful. 3D map not going to help you this too much because 3D map you're going to look at the unipolar signal. Your bipolar signal is going to be from endocardium. So it's going to be a huge difference. Then you have to make a decision what to do with it. So having local catheter can be the earliest local bipolar signal with the two French catheter. At least you can guess where it might be, and then you can target empirically.
Then at the start of the procedure, you will have microcatheter CS at the start.
Yes, we put a very beginning. So the first step it would be his bundle, RVR flush rate above the pulmonary artery, bipolar catheter for the reference to see how diverse it is. And then we put a coronary side of the SR1 sheet with the ablation catheter, and then I will do global coronary angiography. Then that guide on that, I can put a guide wire over JR4 or either GlideCat catheter. GlideCat catheter is a peripheral angioplasty catheter, very soft and it has a right angle. SR5 or SR4, R5 have this kind of a kink at the end of it. Sometimes they are too big to engage the small branch. So I do use GlideCat more than actually JR5 or JR4. So that way it's softer, doesn't dissect. That's another thing. And then you can basically look at your baseline angiography, areolar view, find which vein is your candidate with angioplasty guide wire. Do that, engage that, GlideCat into the os, and then you put the two branching. Very straightforward. Okay. Only trouble that a lot of time veins are small initially, but the trick is that if you leave the sheet catheter in there for a while, the vein, because of blood flow get a little bit slower, can be larger. Because these veins go spasms. So that actually the veins are bigger than you think. Okay? So that's why a hip hop argument is that why don't you put Agilis sheet in there? And then because of you pain group, Agilis sheet there, Firmina Garcia. Question, the problem of that is that you gotta make sure that you're not dissecting it. Agilis sheets are pretty stiff. So main concern is that you may dissect the main point sites, then you're not getting to that area. Or you have to wait another 30 minutes, something like that, to establish the channel and access. So I personally don't think that is good for us in our case, especially Korean patients have smaller cardiac vein than US guys. If you think about that too, there's a attrition variation. So we like to press I want you safely with the EPT catheter and it would stop first, put in the main body, shoot a picture, take a look at the nut, where the valves are, where the angle is. And a beautiful picture. Okay. And then I review, use that as a vote.
Once there was a patient, and I'm trying to put a microphone.
Mhm.
Maybe dissect was no good.
Right.
So I pulled all out.
No. So what you want to do is wait. The venous dissection is a low pressure dissection. Okay. The main flow keep coming forward, retrograde through the front side, they open up. So you wait about 30 minutes, you will see the injector gently another contrast, you will see the pain channel. And you can guide it out with the angioplasty guide wire first. Now, biggest problem that I see my fellows that are doing this is that they try to push JR4 or either glycat directly into it. That's a mistake. Don't do it. What we do, we put a guide wire, make sure you pass the target vein, okay? Then you put the catheter in, you're pulling out and shooting the injection. You're not actually pushing in the catheter. Make sense? You're pushing in as sharp edge is going to dissect the vein. So if you did your vein, same thing. So what you do, you got to make sure that you pass the target vein with a guide wire, take guide wire, put a catheter, and you end the pole, you have a white connector, right? The center goes 2 French, beside we inject the contrast. Like angioplasty, same setup. And then pull back gently, keep popping until you confirm it, just push it in. Other option is you can just keep the guide wire, angioplasty guide wire, push it in, push the guide wire back in, and draw a big drawing. Once popped it, you see the vein, you guide 0.14 guide wire, put it in inside of that vein, and then try to engage your guide over the angioplasty guide wire. That would be safest. Like a PCI, that's what you're doing. And then once you confirm it, take it out guide wire to French in. The both techniques are wonderful, good to do this. But biggest mistake is that they try to rotate a catheter without guide wire, then that's it. This is a problem. Because these veins are as fragile than what you think, much fragile. So be careful with this stuff. Now, if you dissect the tamponade, no, unless you perforate with an ablation catheter. Okay? We never had the dissection in this tamponade. Like your PC, your LV lead replacement, same thing. Sometimes we put a guide wire go out of the cardiac, pull that, nothing happened because it's a low blood vessel, and then they clog up right away. Okay. And then also another important message that you have to tell you: if you dissect, you see this flushing of the contrast, right? Where you think that it's in the fat tissue, it's not in the vein. These veins are protected by the fat tissue. Remember the anatomy? So those is important. Okay, and you seldom stay in pericardium. It's like a flower, right? So that basically cardiac extravasation, compression of that fat tissue, compression of vein. So wait there, observe. Okay. So you did ablation, okay? Take a look at the map since you presented. Okay. Where do you see this? Eric Bob is up there. This is what you call. You call summit? Is that really, you only be one, show me one video so I can tell, but I'm not sure this is summit. This is probably here to my configuration almost. Summit would be higher, almost up. Yeah, not that low. So I think this is the most lateral aspect of air to mitral contiguity. Okay, that's why I prefer air to the mitral valve. That's what I would say. Then with the ablation signal, I don't barely see that. Okay, it's not that early either. I can look at it, but maybe 20 milliseconds. Typically, when you see focal PVC, you feel comfortable if your local signal is minus 28 millisecond or higher earlier. That's a cutoff. Many statistical studies done over in the last 20 years or so. European guys, they look at the data, also US, look at them many years ago. You look at it, if your local EGM is not the far field, okay? The earliest reference to QRS complex.
Hi, good morning. Can you all hear me?
Yeah, good morning.
Hey, yeah, hi, how are you?
I'm good. Thank you so much.
Thank you very much for the kind invitation. I'm the panelist, so who's the speaker?
It's me.
Oh,
So
hey, how are you?
I'm good.
Well,
With Professor Kim.
full disclosure, Dr. Chi from Malaysia actually asked me. Yeah, we haven't started yet, right? No.
Yeah, maybe. Professor Kim.
Yay! Hi, Professor Kim, how are you?
Okay,
I'm good.
thank you.
so
Thank you
much.
for joining our conference. It's already seventh time. Yeah.
All
And
right, yeah.
yeah, usually we start in 9 o'clock. So yeah, we will start after 2 minutes. Okay.
All right, sure.
Okay.
Professor Kim.
So
Great effort
Dr.
from.
Eng, you can share your slide.
Yeah, but please
Yeah.
allow me. Maybe you could allow like in the Zoom, please, because right now I cannot share my slide.
줌 슬라이드가 저기 쉐어가 안 된다고 하니까 혹시 확인해 주세요.
Okay, it's work right now.